have questions, there's mics set up here and here. If you're online, you can tweet your questions to hashtag
You can raise your hand,
SpondyStream.
and I'll repeat the question.
Yeah, that works too.
Yes, ma'am.
In the study you had done on 10 or so?
So the question was, the Embrel study that we showed you, there was 30% of people who got better. Was that a real response, or was that sort of just anecdotal? No, that's a real response based on a very difficult multi-definition of a response. You had to improve your labs, you had to improve your measures, you had to improve your pain, you had to improve quality of life. You know, there's a bunch of things would go into that. So those are real, unequivocal responses. And yes, it happened to people on fake medicine. And what's that tell you? That tells you the power of the mind. When I'm putting people in a study where they're going to get a 50-50 chance of getting real drug or fake drug, they're like, I don't know, you know. But I can tell you, I've seen people with, it's hard to tell an ankylosing spondylitis. In rheumatoid arthritis, it's very easy. They got all these swollen joints. Their hands look like a bunch of grapes all over, and they can't close their hands. And I've seen all that go away. Objective, swelling, warmth, heat, pain, go away just on placebo. It's the power of the mind over the body. And can that be sustained? Yes, in many cases. The traditional thought was that a placebo response wasn't sustained, but in some cases it can be. But in general, it's usually not sustained as long as being on drug. Would I continue the placebo responder on placebo? Number one, I don't know that. When they are done with the study is usually not over. And they don't unblind me to what that person got until 6 months or a year and a half later. So I got to treat that person now. I'm certainly going to put them on Embrel or whatever the active drug, because the good thing about studies is that you get placebo for a certain period, 12 weeks, right? Usually not much more than that. And then after that, you can then roll over into the real drug and see how much better you get. So placebo responses are real, but the studies show not as good or as long as sustained as the drug. If the patient wants to stay on, and the patient doesn't know, again, you're sort of stuck. You need to do something. If the patient's feeling better and they want to assume it's placebo, they can choose to not go on the active drug, in this case, Embrel, going forward. But most people want to ensure how well they feel. So most people do continue on the drug. Yes, sir?
What is the dropout rate for people that are on placebo in trials?
The question is, what is the dropout rate of people on placebo in clinical trials? It's directly proportional to how long you're on placebo. Because when you're on placebo, when you're in a clinical trial and you're not doing good, you're worried, darn, I'm on placebo. I know I'm on placebo. It's just my luck, I'm on placebo. And everyone who has spondylitis has this sort of Damocles, this black cloud over their head, thinking everything bad is going to happen to them. I'm sorry, that's actually wrong. And that has no basis for other than this is the way we all think. You know, when you're getting dressed, oh, this is not good. I shouldn't wear this skirt with that thing, you know. And, you know, or what do they I know they think I'm an idiot. There's this negative voice in our head. You know, I've written about that on my website called it diabolical negativism, that the idea that all bad things are going to happen to me. So when you're in a study, you believe that you're going to get placebo because it's just my luck. Even when I have some studies where it's a 25% chance of getting placebo and a 75% chance of getting real drug. The bottom line is, though, dropout rates. If they're short, the exposure to placebo is 12 weeks, certainly, or no more than 24 weeks. The dropout rates are single digit, you know, 4, 3, 5, 6, 9%, and usually not much different than the active drug. The longer the time that they're on placebo, then you start to see a separation. There's more dropouts on placebo and less dropouts on drugs. So a 6-month or 1-year study that had placebo, you might see 15% dropout on placebo, but only 6 or 7% dropout on the real drug. Why do people on the real drug drop out? Guess what? They're thinking negatively just like the guy on placebo. Darn, I'm not doing good. I'm sure I'm getting placebo. We've done studies where we show people on the real drug drop out thinking they're not doing well, and they're kind of a little bit better, but not great. And, they are better. They meet definition for response, but they drop out nonetheless. And then they go on the real drug, and they get better. But they were on the same drug the whole time, okay? So again, it's your mind is a great thing that sometimes can work against you if you're not careful. Yes, sir?
Well, it's hard to
Heart conduction, a very good question, I'm sorry. A conduction disturbance in the heart has to do with the frequency and the rhythm of the heart. So a normal heart beats in a lub-dub, lub-dub, lub-dub fashion. That's the atrium ventricle, lub-dub, lub-dub, lub-dub. And it's like clockwork, 60 beats per minute, all evenly spaced. When you have a heart conduction problem, the electrical signals that go from the headquarters to the ventricles is disrupted. And you get irregular rates, and now it's lub-dub, 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 it's like beating at crazy rates, or it beats incredibly fast. Examples of this would include things you may have heard like atrial fibrillation, AFib, or ventricular tachycardia. Those are two examples, and it's not good to have that because it could lead to symptoms. It could be the sign of a problem underneath, not just an electrical problem, but could be, the electrical problem could, in this case, not be due to the disease and inflammation, but could be due to vascular disease that could lead to a heart attack or be the sign of a heart attack. So that's what the conduction disturbances are about. Yes, sir. I'll come back.
Why is surgery not a solution for the fused joints, at least the major fused joints? Why are doctors not willing to do that?
Why is surgery not an option for people who have fused joints? Number one, you don't care about the SI joints. You're not going to have a baby. Fusion in the pelvis, those little SI joints, they do very little for your ability to do this, all right? That has nothing to do with that. It accounts for about less than 5% of your ability to bend over, okay? So you don't care about that. It's when you get fusion above the pelvis in the lumbar and thoracic and cervical spine. Yeah, but there's no surgery to do because you have to laser out all those bridging bony syndesmophytes. And to undo what God has ordained or what the biology has ordained is always fraught with much more difficulty and there's no really, it's not a disc problem. It's not like when you have disc disease. When you have bad disc disease, okay, which is the closest thing we can talk about here, you get really bad disc disease, and you can get the same bony bridging, except in that case, they're big, bulky barnacles, and the big piece of bone just glommed onto the back. They can remove that. They can put in new discs, but what they tend to do is that generally doesn't work, by the way. What they tend to do in people with really bad disc disease is fuse the spine, because that's the only thing that works. You can't make the spine more mobile through a surgical procedure. That's just not going to happen. Will it happen in the future? You'd have to basically roll back the clock on the biology of what's going on to get to a more natural state. When I had my knees replaced 5 years ago, they were pretty much shot from football and 30 years of damage, but they gave me brand new knees. I mean, and now I can go to the fair for 10 hours a day and walk all over Paris, and I could never have done that, 6 years ago. Unfortunately, the same equivalent thing doesn't happen in spondylitis in the spine. Yes, ma'am.
You mentioned how prevalent the genetic link is for B27 positive AS. Is it as prevalent with B27 negative psoriatic arthritis?
So is B27 important in psoriatic arthritis would be your question?
More so, are there genes that make it likely that your first relatives will...
Yeah, psoriatic arthritis is certainly a connected but different disorder. The presence of B27 in any of these disorders just increases the likelihood you're going to have spinal disease. It just increases the likelihood you're going to have a risk of uveitis. So psoriatic arthritis says B27 is more likely to be the 20% of psoriatic arthritis, of which there's 5 or 6 different variants, 20% of whom will have spondylitis, but then skin disease. If you're B27 negative and you have psoriatic arthritis, you're the rest of psoriatic arthritis, which does not have a clear genetic marker. There's a whole bunch of them that are putative ones that the gene jockeys love to, no, CW6 is really important. It's not. I mean, this doesn't play out, and it's not important enough to teach patients about it. Nice question. The question is, if you were on a TNF inhibitor and you didn't respond, what's the likelihood you respond to the newer medicines, the IL-17 inhibitors? And the answer is very well, enough to get FDA approved, but not as high if you're TNF naive. So if you never got either biologic and you got an IL-17, you'll do as well as if you got IL-17 or TNF, okay? But if you were previously on TNF and you failed those, and you failed them as a primary failure, meaning you took it and you never got better, your response rate is now, instead of being 60%, is usually 10 points lower. So it's 60 goes to 50 in that patient, or 50 to 40 or something like that. But it still is much higher than placebo and definitely worth a try. Yes, sir?
Are the side effects, negative side effects of the IL-17 similar to other TNF drugs?
Well, this is where you should go to rheumnow.com and get the patient handout on side effects. So are the side effects of IL-17 inhibitors equal to the other drugs? The answer is yes. But I would say pound for pound, these drugs are way, way, way safer than any drug that you've ever taken for this condition, including the anti-inflammatories, including over-the-counter Advil, has more danger than taking Enbrel, Humira, secukinumab, any of the new IL-17 inhibitors. Well, you could say that because, number one, I'm a consultant for these companies. I do research for these companies. I fight with these companies all the time, but my focus is on drug safety. I write a lot about drug safety. I watch drug safety. You know, I got that from being on the FDA and whatnot. And I can tell you, really, pound for pound, they're better, because what you see on TV is designed to do what? It's designed to sell drugs and protect their butts. Okay, so they got to tell you the ugly stuff. You know, blue eyeballs, greasy diarrhea, and you may die, right? And you're like, why would I take this medicine, right? But someone's running through a field and looking good and all this kind of stuff. It's just so totally confusing, but it does sell drug. It takes a really good drug and makes it $1 billion drug, all right? But the fact is that everybody in this room is going to get one cold a year, and if you're on Enbrel, Humira, Remicade, whatever, you're going to get 1.5 to 2 colds a year. That's it. They're the most common side effects seen in those clinical trials, but they're the most common side effects seen in people on placebo. Okay. So those are not very important, and I mean, but there are a few people, because they keep hammering home on infection, infection, infection. But think about this. I can tell you, I know for a fact what drives infection. Not the drug, inflammation. You have uncontrolled inflammation that increases your rate of infection by 2 to 6-fold, right? You have uncontrolled inflammation that increases your rate of cancer and lymphoma significantly, 1 to 5 or 6-fold. If you have uncontrolled inflammation, increases your rate of heart disease, including heart attacks. So controlling inflammation is the thing. But if you have inflammation and you take prednisone, prednisone's a bad risk factor for infection. These drugs are no higher than the rate that they're seen in the drugs. If you look at all the clinical trial data, which is the best data, it's not significantly higher between placebo and real drug. In the real world, it does get a little bit different. But in the real world, there's so many other things that are in play. So yes, you should always worry about infection, but I would worry more about the disease, and I would worry more about inflammation than I would about infection from the drug. And everything that really scares you is a 1 in 1,000 risk. TB, lymphoma, cancers, they're really incredibly rare. Have I seen them? Yes, I've had thousands of patients on these drugs. Absolutely, I've seen them. But I've seen them in people not on these drugs too. So the answer to your question, IL-17 has the same side effects. It has the same small risk of serious and non-serious infections. It has very little risk of cancer has been shown with those drugs. It has a potential risk for an unusual fungal infection, that the same one you get thrush with. It's a yeast infection with Candida. People who get IL-17 theoretically may have more Candida infections. In the studies, it did not really turn out to be so, but we'll see now that they're in the real market. Any questions over here? Ma'am in the back, over here. Yeah. Well, if I die and I don't know what I died from, there's no danger. Right? So you got what you got. On the other hand, I'm bothered by that greatly, because, I mean, when someone tells you it's arthritis, learn to live with it, that's like, Come see me. I know, not something I ever say. Not something any rheumatologist should ever say. So yeah, I mean, he needs a clear diagnosis. You sounds like he's not really seeing anybody, or anybody's taking him seriously, and he doesn't believe it's an issue. But I already showed you the complications of spondylitis. You can't see inflammation on an X-ray. You can see fusion on an X-ray, okay? And if he has fusion of his spine in multiple segments, then he needs, all those things are in play. Spinal fracture, higher death rates, lung problems, kidney problems, heart problems, eye problems. There's a lot of reason to get a diagnosis. On the other hand, if he's, your grandfather and he's 68, 70 years old or whatever, and he never had a problem, that's like the guy who says, I smoked all my whole life and I'm 87 and whatever. And I said, congratulations, you're the one train wreck out there, trying to put forward a policy that doesn't seem to work for the rest of the populace. So again, he may be lucky, but he could get a lot luckier and a lot smarter by just seeing someone who should know, either an orthopedist or a rheumatologist or whatever. Anybody else? Yes, ma'am. Ladies first. Are your inflammatory markers always elevated? And the answer is no. Less than 50% of the time, someone who has very active ankylosing spondylitis, not taking a medicine, will have a normal SED rate, a normal C-reactive protein, or CRP, right? So, but yet they still have lots of inflammation. We know that from biopsy studies. We know that from other things that tell us that you have inflammation. There are other tests, like if you have chronic inflammation, you'll become chronically anemic. If you have chronic inflammation, you may get low albumins, you may lose a little weight. There's other things that you can look at besides those two specific inflammatory tests. Yes, sir.
If someone had tried the Embroil and the other drugs and it didn't work long time ago, and they're on low dose of prednisone now, and it helps them, should they try to get back on the Embroil or one of those?
So if someone had tried Enbrel and the other drugs, we'll assume like Humira or whatever, before, and they didn't work, and now the person is taking 5 milligrams of prednisone, and should they go back on those other drugs or try something new? My first question is, what's the diagnosis? Because prednisone makes everybody better. I don't care what your problem is, it makes everybody better. Prednisone, on the other hand, is acutely wonderful. So when you come into my office and you're a mess, I can make you better like this with a big dose of prednisone, whatever the mess is. But if you take prednisone chronically, it's dangerous, hazardous. You're going to get fat, hypertensive, diabetic. You're going to have weak bones. You're going to get fractures. You're going to get weak muscles. You're going to be exposed to more infections, weird infections, bizarre infections, death from infections, stomach ulcers, cataracts. I can keep going if you want. But chronic steroids are a bad idea. And anyone who's relying on steroids is not being treated properly. All right? So I'm not sure what the option is, but if you failed multiple TNF inhibitors, going back to that would not make sense. Okay? Are you a rheumatologist? No. Are you a plant in the audience here to confuse me? You sure? So that's that's a question that rheumatologists deal with, and a good one. And the question is, can you take two biologics at the same time? Would that be better? Could you take a Enbrel and this new IL-17 medicine together? The FDA frowns upon that and warns against that. The combination of two biologics together may substantially increase your risk of infection without giving you a substantial increased benefit to your arthritis. But you specifically bring up another biologic, not in the world of inflammation control, but of bone improvement, and that's the use of Prolia, denosumab, or Forteo. And those can easily be combined with TNF inhibitors and other powerful anti-inflammatory drugs without any increased risk. That's recent research that's evolved in the last 2 years, but it looks like there's no added risk to those people. All right? It'd be far, far worse to not treat both conditions. One and then two.
I'll allow you to be slightly self-serving. You have two websites that you've talked about, Rheumatology and RheumNow. Is one for doctors and one for patient education, or are they both accessible?
They're both accessible. Rheumatology, which knowledge, and then rheuma on top of it, or rktext.com is a textbook. So, if you want to look up a drug, any information that's there. I wrote that textbook with 2 other doctors to provide rapid, easy information that's what I think sort of easily written for residents, fellows, people in training, doctors, patients, doesn't matter to us. So that's a website for everyone, and that's called rheumatology.com. Rheum Now is my daily publication. I put that out Monday through Friday every day. It's designed for rheumatologists. I have 3,000 plus followers. About 25% of the population, of the followers are patients. So if you have an interest in this stuff, but I don't write it for patients. If you want to follow me on Twitter, @RheumNow on Twitter, I put out maybe 1 out of every 6 things I put out, or 1 out of every 4 things I put out are kind of for patients too. But my Twitter feed ends up being incorporated into my website as well. So if you go to my website, you can decide for yourself whether it's useful to you. Like I said, right now there's a patient guide to biologics, which is a useful download for doctors and patients. And so you're certainly welcome there. But I originally set out to write a website, especially the Rheum Now, that would be for patients and for physicians. But in the end, I found out that would be a big problem when it comes to, I don't yet have any advertising support, and I could, and I intend to, but you can't really get advertising support if you're going after the 2 different domains, and because advertisers look at those very differently. Yes?
Thank you, Dr. Cush. I have a question from our online streaming audience for us. Okay. What are some effective non-medicinal or complementary treatment options for spondylitis?
Ooh, this is where I really get in trouble. So my job as your physician is to help you and protect you from harm, and to educate you. And so everybody's on, 1/3 or more people taking complementary medicines. And you often that's ill-advised and not well, everything's got a good claim, but nothing really has a full story to it. I'm very well, my partner and I, Dr. Dow, and our practice, we're very well versed in this. We're totally in favor of complementary therapies when there's some good evidence for their use. So, most things, however, there is no evidence. So, number 1 rule is the more it costs, the less it works. Okay? So if you're investing in complementary therapies and it's an $80 bottle of something, you're wasting your money. And I'll guarantee that pretty much all the time. Because all the complementary therapies that are actually useful, whether it be cherries or turmeric or antioxidants, but nonetheless they're all cheap. Glucosamine is a total waste of time, especially in this condition. Again, we'll talk about it and go forward. We had a few patients though who came in and wanted us to advise them on diet, and I've tried several people on gluten-free diets, and that's very faddish right now. But whereas I cannot say that it works for most people with arthritis, I can say that if you have psoriatic arthritis or psoriasis, and probably even ankylosing spondylitis, a gluten-free diet is beneficial based on our experience, which is about 300 patients. Now, we don't have a placebo-controlled study to prove that, but by gluten-free, basically no bread, no pizza, you have to be very careful about the grains and educate yourself on gluten-free. It's got to be coupled sort of with a low-carb, no-carb diet. So you're basically very rich in protein and vegetables and fruits, and it really does seem to help. Now, what do I base that on? Patients coming to me who have psoriasis, only psoriasis. And I say, you can go on methotrexate, you can go on Enbrel, or you can go gluten-free. They go gluten-free, they come back, they have no psoriasis. Someone who has really bad spondylitis, not well controlled, partially controlled on a TNF inhibitor and multiple nonsteroidals or whatever, I'm getting fewer in my choices for them, make them go gluten-free. Now they're well controlled and they stop taking their nonsteroidal. So complex cases can get better. Early cases can avoid these more invasive medicines, but you have to be 100% rigid with a gluten-free diet. What is that doing? We believe it's making changes at the level of the gut in the microbiome. To digest gluten, for not everybody, but in general, requires an inflammatory reaction at the inside of the gut, in the luminal mucosa. And in some people, it's an explosive, pretty aggressive inflammation for you just to digest that one piece of gluten. That becomes fuel for inflammation in other parts of the body, whether it's your eyes, your skin, your joints. So again, it may work in some, it may work in, but we don't know. We hope to study this in the future, but until that, we're advising people a gluten-free diet would be a reasonable option for a lot of people. Yes, ma'am.
Going back to the multiple autoimmune diseases, we have a lot of people in our group that have undifferentiated with psoriatic and also with Sjogren's and then some other stuff. What's your take on that?
Well, so the question is, going back to people with seronegative or having multiple autoimmune things, especially if you're seronegative or you're called undifferentiated, and then having other disorders like Sjogren's. Sjogren's is dry eyes, dry mouth. Somewhere between a third and 40% of people over the age of 60 have dry eyes, dry mouth, but none of them have Sjogren's. All right, so to have Sjogren's syndrome, you need to have dry eyes, dry mouth, other dryness elsewhere, and you have to have an autoantibody that proves it, an ANA, an SSA antibody, SSB antibody, or you have to have a lip biopsy that proves it. The vast majority of people that I see that have Sjogren's syndrome don't have Sjogren's syndrome. I don't really care because there ain't no treatment for it. It's not that I don't care. I care greatly, but I don't have anything for you. You got dry eyes, dry mouth, guess what? Eye drops, and you got to have a water bottle the whole time and get good dental care. Because Sjogren's syndrome, if it is Sjogren's syndrome, is an autoimmune attack on the glands that cause you to make spit and tears and other moist things, and they get damaged and they don't ever recover. The inflammation's gone. It's a hit and run thing. So there's nothing left for me to treat. I can't treat that with powerful drugs or whatever. So I don't, fine, you got dry eyes, dry mouth, Sjogren's, not Sjogren's, don't care. Problem is that 50 to 60% of people with Sjogren's syndrome have fibromyalgia. Fibromyalgia is what? I hurt all over, I'm stiff all the time, I sleep like crap, and did I say I hurt all over? Okay, and guess what? All my tests are negative. So what some doctors call that, I would call that fibromyalgia and Sjogren's syndrome. For me to call that spondylitis, I need some of those features of spondylitis. I need uveitis. I need inflammatory heel pain. I need a SED rate and a CRP elevated. I need an MRI showing sacroiliitis. I need an X-ray showing fusion. Short of that, I'm not calling it undifferentiated. That's like me hoping that you get something later on and I can treat you from now until then with drugs that may or may not work. Again, I tend to be a very black and white physician and very direct and get a lot of trouble for that directness, but that's okay because there ain't no waffling here, and I'm going to be wrong about wishy-washy 5% of the time, and I'm okay finding out I'm wrong because everyone's going to be wrong at some point, even doctors, especially doctors. We're getting the best evidence we can, and that story can change over time. But often people who come to me with a story like that, Sjogren's, undifferentiated, whatever, they got a long story. They've got 5, 10 years of something. Well, we've had plenty of time to get the whole shebang, to make the diagnosis of spondylitis or not. If we can't make it today, then we're never going to make it. So again, I still believe that you really can only have ankylosing spondylitis, spondyloarthritis. Undifferentiated spondyloarthritis is an older diagnosis that we often use in the 80s and 90s and 2000s. Now we're getting more into more specific names, axial spondyloarthritis or ankylosing spondylitis or peripheral spondyloarthritis, et cetera. Okay? All right, one more.
In addition to diet, exercise, getting plenty of sleep, what is
Yeah. Well, first off, I want to thank you for A, being here and supporting your husband and trying to understand the condition. B, the reminder of diet, exercise, and plenty of sleep. I should have stressed that way more than I did. Because I think diet is good. If we're all vehicles. You can put low-octane nonsense in your tank, or you can put high-octane good stuff in your tank, and so a diet becomes very important. Exercise, movement is good. When you get at your worst with these conditions is when you don't exercise and you get weak. Weak is associated with pain. You want to have less pain, get stronger. That's an easy thing for me to say and a hard thing to do. But the more strength you have, the less pain you're going to have. And then great sleep. Sleep is where we go to retool, reboot. If you're sleeping lousy, you got to fix it because it takes whatever's wrong with you and makes it worse. So you got migraine headaches. If you're sleeping bad, you're at the migraine doctor all the time. You got back pain problems for whatever cause, you're sleeping bad, you're at the back pain doctor, the rheumatologist all the time. Fix your sleep, and you'd be surprised how much easier those other things are to fix. You asked about other things like massage, chiropractic, throw in acupuncture. None of them proven to be of any value. Okay? Massage it's like prednisone, makes everybody feel good. Except prednisone, you feel good for a few days. Massage, you feel good for a few hours. Okay? Now, if I had spondylitis and I was married to a woman that wanted to learn massage, that would be a good investment. But no, honestly, I don't think that and I'm not against them. I just want to recognize the limitations of them. Chiropractic works when it does work, by being a repetitive daily form of physical therapy. So therapy does work. Stretching and movement and therapy definitely does work. So a physical therapy program, and sometimes chiropractic, but I worry about chiropractors and most chiropractors don't do any spinal manipulation in someone who's got a fused spine, cervical or otherwise, right? But if I had a fused spine, I would not let them do any manipulation. I let them stretch me out, I'd let them, put the roller on me, I'd let them do TENS and other things, but those are mainly physical therapy things, and I personally prefer a physical therapist as opposed to going to a chiropractor. Okay? Yes, ma'am. Last question. Yes.
I'm also a spouse of a woman with ankylosing spondylitis. Can you describe what exercise means?
Oh. You don't agree with that? Well, let me ask you, do you guys often agree on TV channels and thermostat temperatures? Okay, so I should be a lawyer. Well, exercise is something, first off, you want to confuse a doctor? Because we are saying, you got to exercise and you got to improve your diet. You want to confuse the doctor? Say, well, what exactly do you want me to do in my diet? And they're like, they ghost and, I don't know. They'll just throw out vegetables and, no Big Macs. But because most physicians aren't very well trained in either of those subjects, diet or exercise. We tend to know what does work, and I think that, first off, I would say, as much as I want to be very good at what I do, and I want to give the best advice that money can buy or that I can give away, I don't think you're going to get exercise advice from me that's not better done by the Spondylitis Association of America. Meaning their website and their advice and their programs on exercise are well researched and are highly valuable. So I would start with them first. And then get your doctor to back it up or to tell you why you can't do one of the many things that they recommend in their videos and in theher handouts. So number one, everyone can do great in the pool. There's almost nobody you can't, unless you just had surgery and have something that's open and oozing, you should be in a pool, okay? Problem is, nobody wants to go in the pool because I got a bathing suit and it's November and, there's 18 reasons why you don't do it. And I prescribed pool myself for 25 years until I finally got in the pool myself. I love the pool. And I figured out why people hate it. It's just because it's vanity, number one, and that you've never done it, number two. And it falls under you don't know what you don't know. So, you know, when someone's telling you to use the pool, it's low impact. It's great resistance, meaning it actually helps you to stretch out. And it's great aerobic fitness at the same time. You can do anything in the pool. You can just flop around inside of an inner tube, as far as I'm concerned. But water walking, power walking, water exercise classes, Zumba in the water, it doesn't matter. I mean, you'll do great in the pool. Walking is certainly cheap and easy and free, but it depends on what you've got going. A lot of people with back problems, walking can be the hardest thing that you do. But then again, if you have inflammatory back pain, walking and running or some kind of lower extremity movement is very important in improving your low back. But again, if it's spinal pain we're talking about, pool is number one, walking is number two, elliptical and certain cardios are good. Bicycle maybe for some people, but again, you can have limitations if you have hip, knee, or heel problems with a bike or with walking and whatever. So footwear becomes really, really important. And what I learned is that you either need to invest in a really good, expensive shoe insert inside of a Reebok that's on sale, or you need to go to a really good shoe store and spend $150 on a pair of shoes that will specifically look at the way you walk and try to help you deal with your problem, because they'll stand by their product and give you a new one if that's not working. But those are the main things. You know, guys want to do, you know, exercise. They want to lift weights. Okay, testosterone's up, you feel good, we're done. You didn't do nothing, okay? Weights are good for tone and good for osteoporosis, but they're not going to necessarily fix the things that you got wrong with you. It has to be aerobic fitness, okay? Yeah, I don't know, the average, the goal should be at least 4 times a week for at least 20 minutes, probably 30 or 40 minutes each time. That something gets your heart rate up and moves your limbs, but stretches out your spine. Yoga, Pilates, and Tai Chi. I strongly would recommend Tai Chi for anybody who feels like yoga is too either new age or too much on the floor. When you do yoga, you're up and down off the floor. It's kind of difficult. You can also do chair yoga and chair Pilates, and then Pilates is a little all about the core, a little bit less on the floor than yoga in some classes. But any one of those three, again, Tai Chi is the easiest and is the most upright and has been shown in studies to be very beneficial and equally effective compared to physical therapy, okay? And for someone who, you're the spouse, my wife has ankylosing spondylitis, but she is resistant, she doesn't want to do it, you know, she doesn't think she can do it, she hates the idea that she has to do it, she also doesn't like having disease, you know, she doesn't really like taking the medicine. She argues with me about the thermostat. You know, we're having a hard time, you know, dealing with this here. You know, the best thing to do is get physical therapy involved. Get the doctor to say, absolutely, physical therapy would help you, and get that spouse to agree to go 3 days a week for 12 weeks. To learn what they need to know, to learn what they can do if they did more, to change, again, their activity level, which exercise today has benefits tomorrow, but it really has benefits 10 years from now. 10 years from now, you're going to be a whole lot weaker. And remember I said earlier, strength is less pain, weakness is a lot more pain. We'll end there. Thank you very much for your time.